Hey Cam followers, a little bit later than normal. We're here at 7:30, but I am really, truly so proud of Cam to be able to host this wonderful guest tonight. So please meet Dr. Louise Clark from Davies Veterinary Specialists. I've seen the presentation she's going to give tonight. I saw it many months ago and immediately emailed her, "You're not leaving without doing this on Cam," and she very kindly has 6 months later agreed to give the same presentation. You're going to be blown away. Now, I won't lie, it is going to be a little bit higher brow. Now, sit pretty, listen to the best of your ability. If you've got questions, we will have breaks where we can go back over certain concepts. Now, I'd like to say thank you to our sponsors for tonight. I'm really, really grateful to Animal Care for seeing the importance of this topic. So thank you, Animal Care, for getting behind Cam and supporting us. If other companies love what we do, please get in touch, because we are self-funded putting this content out there. So Louise, tell us a little bit about yourself before we start your presentation.
Yeah. Hi, I'm Louise. I'm an anaesthetist at Davies Veterinary Specialists. I'm ABVS, RCVS specialist in Veterinary Anaesthesia and Analgesia, and along a long career I've also picked up a master's degree in clinical management of pain and fellowship at the Royal College. I spend a lot of time anaesthetizing referral cases and quite a bit of time with my colleagues through different disciplines here, managing some of our complex cases, be they osteoarthritis cases with lots of comorbidities, or some of the neurology cases that we can't do surgery on. So yeah, I guess that's me. Primarily, I'm a clinician, so although what we're going to be talking about is pretty much is quite heavy, I accept that. There's quite a lot of pathophysiology and quite a lot of stuff that, frankly, as a vet, I was never taught, not until I got to master's level. But hang in there, I'll try and make it as digestible as possible, because I know there are vets in the audience, and for the owners out there, I want your vets to understand what's going on too. So hopefully it'll be broken down into a way that is comprehensible. That's if I can make my screen share work. So shall we give it a go?
Let's give it a go. So I'm going to have a little tab appear any minute now. Yes, there we go. So you are live, Louise. I've got your front slide. I am going to let you do your thing.
Okay, so I guess to give a bit of background on this, one of the things that a lot of vets and a lot of people in general struggle with is, what's the difference between acute pain and chronic pain, and what do we do about chronic pain? And we're talking about osteoarthritis, but this initially is a bit of a concept thing. So chronic pain, what is it? Why is this still painful months and months later? How do we approach these cases with chronic pain? And a little bit about clinical pharmacology. Bear in mind, I've been at work since 7:45 this morning, and I don't still want to be here at 10 o'clock, and I'm pretty sure you don't either. We're going to try to get this into about an hour, so it's an overview and no more than that. So what is chronic pain? A definition. Chronic pain is defined as pain that persists or recurs for more than 3 months. In chronic pain syndromes in people, pain can be the sole or leading complaint. And what this really means is that if we look at the patient from a clinical perspective, from a point of view of what is the disease, we can't find anything that's the disease. We can just find pain. And we don't really see that in animals. But if we think about the osteoarthritic patient, many of them have got pain for more than 3 months, so they're definitely defined as having chronic pain. And how does a chronic pain differ from acute pain? So generally, in a situation of acute pain, there is a really close connection between what you do and how severe the pain is. So obviously, if you stick a needle in your finger, if you burn yourself on the grill, it's going to be a little bit sore. If you have a road traffic accident, it's going to be massively sore. Unfortunately, in chronic pain, disease and pain are not well correlated, which is sometimes, pain is not an imaging finding, and this is relevant to our cases. They may not have really severe imaging changes, but they can still be very painful. Chronic pain is what we call maladaptive. It doesn't have any really good function. Acute pain is really useful. Every time I try and cook and burn myself, I need to know what pain is because I need to remove my hand from that grill and let my husband do the cooking. And chronic pain is of no use to the patient at all, as far as we know. So because it's of no use, all it does is it exists as a chronic stressor. And we all know, we've all been there the last 2 years, chronic stress is not good for any of us. And I think this is really important. Chronic pain is not just about how it feels, but about how it makes you feel. So I can go for a run, be unfit, and be 2 out of 5 lame tomorrow, but it's not making me feel awful. If I was 2 out of 5 lame for a long period of time, it probably would make me feel down. So it's not just about how it feels, but about how it makes you feel. And that's really well documented in people. There's quite this Scandinavian Journal of Pain reference is really useful. And pain is what the patient says that it is the gold standard for pain for pain in human practice. Unfortunately, our patients can't talk, but they most definitely can express. And we were just talking before the webinar about what that means, and that's just so much more than a physical examination. It's a behavioral and it's a concept thing. So what is the patient expressing? So what do I mean about, it's how the patient feels? Well, if you think about acute pain, what we want to know is when you've burnt yourself on the grill, I just did it now, it's hurting my finger and it really hurts. So that's what we call the sensory discriminative bit of pain. Where is it and how much does it hurt and how fast do I need to move out of the way? This is not a big component of chronic pain. What's much more important in chronic pain is what we call the motivational affective component. This is the disturbance of feelings of well-being or the unpleasantness. And I think to us, it's I just feel pretty rotten. And we know in people that can manifest as anxiety and depression. Anxiety, depression, chronic pain are very, very well correlated in people. And we have some early evidence that is the case in dogs too, which I can talk endlessly about. But it is this motivational affective component of chronic pain that very much differentiates it on a whole animal level from acute pain. So we need to know that all pain is not the same. I've already alluded to that. Acute versus chronic is very different. And if we understand a bit about pain mechanisms, when we're coming to treat it, we can think about what's the appropriate treatment. If we don't understand the mechanism, we can throw drugs at it all we like, but the wrong drug and the wrong mechanism will only expose the animal to side effects. So that's just, it's really, really important basic principle. So fundamentals, we're getting into the physiology, so bear with me. If you don't get it, don't worry, we'll circle back and we'll also talk about it in a much more comprehensible way as we go forward. So this is a quote that is in the journal Anesthesiology, and it states that the nervous system after injury is very different to that before injury. Well, that's kind of obvious, you just put a hole in yourself. But what it means is that our nervous system is not like the electrics in your house. It is not hardwired. What I mean by that is, the electrics are the same today, tomorrow, next week, hopefully. When we expose our body to injury or to a chronic disease process, what we're doing is actually changing that system that adapts constantly. And we know there's lots of evidence that children who've had severe trauma, be that both emotional and physical in early childhood, have real chronic pain problems. And this is because our nervous system isn't hardwired, it's changing all the time. And that's something that we need to think about when we're managing pain. So here we go. What is peripheral sensitization? Well, if you think about osteoarthritis, we talk about it being an inflammatory disease. It isn't truly, it's partly degenerative, but we get lots of stuff released. Things like bradykinin, prostaglandins are the importance in the maintenance of pain signaling. So prostaglandin is something that is basically produced by damaged tissue. So we'll just have a look at that thing to see what's happening in this situation. The prostaglandin, you can see in the little blue circle thing at the bottom, binds to this nociceptor. This is what our funky thing is here. A nociceptor is just, if you like, a pain receptor. And it has lots of different types of nociceptor within the body. This prostaglandin binds to this G protein coupled receptor. You don't need to know anything more about that, but it essentially induces activation of a load of enzymes. And these ultimately reduce the threshold of activation of the nociceptor. So what happens is that previously, if you had to hit the nociceptor pretty hard to activate it, you now have to hit it a lot less hard to activate it. So you get an excited peripheral terminal membrane. So basically, if you look at the thing on the right, you've got a very, very high intensity of signaling coming from that. So basically, what happens is all this inflammatory stuff that's going on in the osteoarthritis is basically making your pain receptors get a bit excited, and you get long-term changes in this. You actually get gene upregulation and all sorts of long-term things going on in there. So you're actually ultimately creating sensitization within that area. And as a slight correlate to make you understand it, is if you had surgery, you will find that you have a surgical wound, and that surgical wound itself is pretty sore. But the area around it is also pretty sore, even though you didn't have surgery just there, and actually no blade has gone in there. That's because of this kind of local effect that you've got lots of release of assorted different inflammatory things that are activated a little bit away from the actual primary site and cause the sensitization. So this is an ongoing process within a damaged joint. So we've got a lot of sensitization out at the level of the joint. And beyond that, this is something that we're going to talk about a bit more when we talk about drugs, but we actually have a peripheral influence at the spinal cord. That's the dorsal root ganglia. That's basically something that just sits just outside the dorsal horn of the spinal cord. We've got something called nerve growth factor is highly involved in pain signaling. It binds to something called the tropomyosin A or the TrkA receptor. And this complex actually gets carried by a very nifty but not very helpful mechanism up to the spinal cord, and that spinal cord then signals down going, let's produce more pain receptors, let's produce more pain receptors. So it's actually a mechanism that goes via the spinal cord. We produce more pain receptors. This is a long-term change. So if you like, pain begats pain by changing the mechanism of pain. That's probably all you need to know, that if you have pain, it's not well managed, you then get a load of other mechanisms that cause more pain. So if we're looking at this from the osteoarthritic point of view, we've got our slightly poorly looking joint on the left that says the periphery, and we've got our nociceptor there, and we've got a whole load of potential pain targets, and we will come on to talk about those when we're talking about appropriate drug management. So if we have a look there, we can talk about nerve growth factor, we can talk about local anesthetic drugs, we can talk about non-steroidals, and I'm pretty sure everybody knows about non-steroidals. They affect this prostaglandin pathway that I've just been going on about. So if prostaglandin is a big driver of ongoing pain and peripheral sensitization, the non-steroidals, you can see quite clearly from that diagram, are something that will stop this process. So we'll leave the periphery for a second. We're now moving up to the spinal cord. Central sensitization, and some vets who are even older than me know this as wind up, which is actually a slightly different mechanism, but it's basically a process through which that you get hyperexcitability in the spinal cord, leading to what we call enhanced processing of nociceptive input. Now, what that basically means, let's ignore most of this slide, is what goes in undergoes a load of processing in the spine, and what goes out gets massively magnified. So for the vets out there, is if you're like me trying to do ultrasound badly, you've got your probe on and you have to turn up the gain on the ultrasound to get a big better picture. This is what's happening. You get a moderate signal coming in and a much bigger signal going out. Well, what's the point of this? There is a survival benefit to it, because if you get this repeated stimulus in an animal who is in a very tenuous situation, if the animal doesn't respond to rescue themselves, basically there is an increase in this, and you basically get an enhanced response. You know, if you don't respond now, I will keep ramping it up until you do respond. So that kind of is okay, but it's not so great if we've already got a magnified input from the periphery. We get to the spinal cord, we have all these funky mechanisms in the middle of the slide, including things like NMDA, receptor-mediated hypersensitivity. We've got all those microglia doing stuff, and we even get to the point where sensory neurons that normally come in saying, I carry sensory stuff, will actually go out and carry pain stuff because they've been sensitized. And I can kind of correlate for you, if we think about it, it's not quite the same mechanism, but it makes you think, is where a normally innocuous input can produce pain. Well, you and I have a shower every morning, it's not painful, everything's fine. You know, we get one great day of summer, we all forget our factor 50, we go out in the sun, we come, and so we sensitize our skin. This is skin being sensitized, but the mechanism is similar. We come back in the shower, a normal temperature shower is now really painful. This is a similar, basically, upregulation. We're increasing the gain of the system. So what would normally come in as being touch goes out as being pain. So I'm sure vets will see animals and you think, God, he's overreacting. And it may not be osteoarthritis animals. These are often animals that have got other stuff going on. And you palpate them and you get a massive reaction and you think, oh, you're being ridiculous. Some of it could be behavioral, but some of it may be because their pain signaling is all over the shop. And I have seen this multiple times, that you put an input in there, you're just touching them. What they're reacting like that for? And you get this big response. So central sensitization could be involved in that. And we often see this in palpation of some of these patients, that you get a really big response because they're so centrally sensitized. So we now know that this goes on in the spinal cord. We've not talked much about mechanisms because we kind of don't have time. But we've got lots of drugs that can work at this level, and we'll talk about those later. So you can already see we're looking at drugs that target the periphery. We're talking about drugs that target the spinal cord too. And now we're going to talk a little bit about the brain. Now, I got taught nothing about this as a vet, and I don't think vets do at undergraduate level. Maybe they do now because they have boring people like me talking to them, but we weren't talked about this. As far as we were concerned, it went up the spinal cord to the brain and that was it. What's really, really important is that pain is in the brain. There are lots of studies that show this, particularly chronic pain. And this, I've got the study up here, and it's Torweger's study, which was it was a really landmark, what we call a landmark paper in the New England Journal of Medicine, so a really, really high impact paper. And what they used was functional MRI, and they looked at a neurologic signature of physical pain, and all those little sections on the bottom right basically show what's happening within the brain when the subject is exposed. In this case, it was just to nociception, to a nasty stimulus, but this has been moved on a long way since this original paper, and this original paper is only 2013. It's not a million years ago. And what we now know is that the brain is the central transmission bit for pain. We call it the pain matrix. And if you remember me going back several slides and talking about when we have acute pain, we're worried about the sensory discriminative bit. We're worried about where it is, what I've done, how to get out of there. When we're talking about chronic pain, we're much more talking about ascending pain that goes via the limbic system. Well, what's the limbic system? It's basically all the emotional stuff. It's the amygdala, the hippocampus, the thalamus, stuff like that. It's really the link to sleep, to mood, to pain. So as we said, mood, depression, anxiety, pain, they're all linked. But this is the motivational, affective bit about pain, which is really important. We also have like descending inhibition, and also descending upregulation. So we know that an anxious person can facilitate pain because what's going on in the brain, they can actually facilitate pain. There's a brilliant study which I've cited a few times before, basically to kind of bring it down. They use a very potent opioid given to volunteers, which should basically completely obliterate pain, and they burned them with cigarettes. They were volunteers, and one level they told them that they were receiving this really potent opioid, and they did receive the opioid, and their pain scoring went right down. And then they got clever. They burned them. They told them they were getting just as much opioid. They didn't give them any. Their pain scoring went right down. Then they did the reverse, different groups. They burnt them. They told them that they were not getting any opioid. They gave them loads of it, and their pain scoring went up. So that's telling you that the brain can override pretty much anything else, which is, it's, I can give you that reference if you like, but it's the Oxford Centre for Neuroimaging that did that. It's a fantastic study. But what it's saying is that the brain is in charge of all this. And we know that in chronic pain, there is a conversion from a shift of the brain activation patterns with this functional MRI. The shift goes from the regions of processing, so the sensory discriminative, where is it, what hurts, what am I doing, to these really emotionally involved bits. So we've got a brain that overrides everything else if it has to, and we have a brain that's emotionally involved in chronic pain. If that's all that you take away from this talk, that the brain is really important in this, that's an awful lot more than most vets know, because we didn't get taught anything about this. And it's really important when we're looking at assessing these OA patients that we're looking much beyond the joint and to what's actually happening centrally. They're really emotionally complex, and so are their owners. So we need to be aware of that. So take home, pain changes the function of the CNS. If you remember that from the pain also changes the function of the peripheral nervous system. Pain changes the function of everything from the joint through to the brain. And we know that from lots and lots of different studies. So that big brain is a lot of a target for analgesia, and that does not just mean drugs. Now, I'm basically just talking about pharmacology today, but pharmacology is a very, very small part of the management of chronic pain in people. So that's something that you really need to be aware of. And much more is about self-efficacy, self-management, self-regulation, management of mood, all these kind of things. So I'm not suggesting that that's a big part of what we do, but I think we need to recognize that the brain is really important in this, and our patients do get depressed, so we need to be aware of that. So you can have a break. Ooh. Hannah, I don't know whether you like that.
No, it's going well. And I think that is a really, really good point for people to just kind of pause and think, oh, because you're absolutely right. I was the same as you. I was taught very much about acute pain, but less so about chronic pain. And to have that massive leap to start thinking of how important the brain processing is will help people stop just thinking it's about the joint. It's the bigger picture. And that's why bringing in all the lifestyle changes and the enrichment and focusing on their quality of life is really important. And to step away from thinking about only the joint or only the pharmaceuticals. So I think perfect. So far, we have not got too many questions. We have got somebody, and I'm going to read it to you, Louise. Thank you for this session. This is very interesting. My pointer has severe OA in the right carpal joint, and when I touch that leg, I get withdrawal straight away. I was thinking it's his expectation of pain, as he knows that leg hurts. I think it's a really good thing to discuss if you're happy, because there is a little bit of unknown there, isn't it? It could be a learnt behavioural response of expectation of pain, or it could actually be, yes, no, that is going to be painful, so please don't do it.
Yeah, I mean, it's a really good point. And, they are, just like you are right, they will learn to do things like that. And I mean, the probably the only way that you could look at that in detail, and I'm absolutely no expert at this, is what's called nociceptive threshold testing, using things like von Frey filaments to actually know whether he has got heightened sensation there, or whether he's just saying, oh, don't come near it, it's going to hurt when you poke it. But if you were to use these things called von Frey filaments, they're tiny little filaments, and they should just be touching the skin. But when you have this allodynia and hyperesthesia and dysesthesia, basically changes in the skin sensation, you get changes in what would be a normal threshold, and the animal, you can monitor and measure that. And there are some smart people, some of my colleagues, who are doing this partly clinically and partly in research to see if we can work out what's going on. But I think it's a very fair point. It could be behavioral, or it could be slightly because you've got hyperesthesia there. It could be a bit of both. And it depends if osteoarthritis isn't associated with as much hyperesthesia or dysesthesia as some of the what we would consider the neuropathic syndromes, which we'll come on to in a bit. But it doesn't mean to say that there isn't a combination, because no type of pain is really that clear. So yeah, definitely you can get sensitization and you can get behavioral change. Does that kind of make sense?
Yeah, and I think so we were talking about this a few weeks ago with another guest and other CAM outlets. There's a big fear about using pain relief in a trial format because people are so conscious of adverse events that sometimes it really limits their confidence of using it and seeing the response. And in this kind of situation where you don't know whether the dog's got a learned response of it hurt before, so don't please do it to me again, or if there is ongoing suffering because it is, as you say, hyperesthetic. In this situation, do you think it would be fair to have a good conversation with the owner and say, well, we're never going to know without trying pain relief and seeing what the response is?
Oh, absolutely. And also, I think we need to, which we'll talk a bit more, is like drill down into the type of pain that we're dealing with, because one of the issues that we see a lot is animals come in and we're looking at the mechanisms of their pain, which may not be osteoarthritis, and then looking at the type of pain relief they're on and going, well, actually, the two don't fit. So yes, I think absolutely. We always weigh the risks and benefits of analgesia, and most of the time it comes down in terms of benefits. Particularly in an animal that hasn't got multiple other problems, multiple comorbidities. But we also need to make sure that we've kind of potentially chosen the right drug, which, shall I move on and start to talk about how we might choose the right drug?
I think that's brilliant. And I think just to conclude that, so having just spoken to Louise about her chronic pain clinics, you are with people for up to 90 minutes having these conversations. So if you are an owner that is unsure about what your dog is telling you, do ask your practice if they provide more lengthy consultations to have that time to discuss that with the clinician. And if they don't, do ask if they refer to chronic pain services like Louise's. So yeah, crack on, Louise, and we'll come back to the questions.
Right, I hope everybody's had time to get some more caffeine on board. So pharmacological management of chronic pain and mechanism-based, and it is very much an overview. So what I wasn't going to say about that, the case we're discussing, but kind of you need to know your pain pathophysiology, because you've got to choose the right fire extinguisher. Now, this is a very basic analogy, but goodness, it works. If you've got a pan of fat on fire and you cover it in water, things are not going to go well. You need the right fire extinguisher for the right type of fire. Just the same, and so we need to try and at least understand a bit about what type of pain you've got. You might not be able to do this. You have lots of mixed types of pain, but let's at least kind of address where the pain type comes from, and then maybe we can kind of think about what we should be doing about it. So nociceptive is basically inflammatory pain. It's a good chunk of what we see in osteoarthritis, and basically the animal is responding to an ongoing noxious stimulus. And in the case of osteoarthritis, you've got ongoing tissue damage, you've got a joint that's really poorly, you've got ongoing chemical activation. So you've got this at the level of the joint, you've got this ongoing response to a noxious stimulus. So we could say that this is nociceptive pain. We also probably in osteoarthritis have this altered nociception, which we were just talking about. We've got changes in the CNS pain and sensory processing. We've got altered pain modulation. We've got the brain involved in this, and the pain doesn't necessarily fit with what's going on at the level of the joint, and it certainly, we don't seem to necessarily have any damage to the somatosensory nervous system. And damage to the somatosensory nervous system is what we would consider neuropathic pain. So if you've got nerve damage, you know, any of you who's been unfortunate enough to have a dog with for instance, a brachial plexus tumor, or maybe they've got a sciatic nerve entrapment or something like that, that's neuropathic pain. It's kind of, the best way to describe it is if you whack your elbow and you hurt your ulnar nerve, you get a shooting pain. It's often called lancinating, and it's one of the types of pain that if a dog is vocalizing, they're very likely to have neuropathic pain because it's stabbing, it's really unpleasant. Neuropathic pain tends to be primarily seen not so much in orthopedic disease, but more in neurological disease. But in osteoarthritis, we have this combination of sort of an inflammatory, noxious soup type pain because we've got ongoing tissue damage, and we have some changes in CNS processing, which you can understand having gone back to the previous slide. So the brain's heavily involved in this. They've been painful for a long time. They've got these changes in the central nervous system processing and altered pain modulation. This nociplastic thing, if you look in any veterinary textbook from a few years ago, it doesn't even exist. It was only defined by the IASP a couple of years ago. So it's new, and it's something that we're all kind of trying to get to grips with. It's basically pain that doesn't fit in another box. So as we said, chronic nociceptive pain, ongoing stream of input from affected tissue. There's damage going on there, and that's a large component of osteoarthritic pain. And neuropathic pain, we've got damage to the nerve sheath tumors, spinal cord compression from a disc, and we get lots of ectopic activity, we get lots of other stuff going on, and basically the ion channels are damaged and changed. And this is one of the bases, one of the roots as well. It's part of the manifestation of phantom limb pain, what's happening to the actual nerves. So dogs that have had amputations, people that have had amputations, their phantom limb, part of this is what's happening within the level of the nerve. So we now know that we've got nociceptive pain, we've got this nociplastic pain, and we've got neuropathic pain. And we've got a joint that's not very happy. We've got a spinal cord that is upregulating and amplifying stuff and being a general nuisance. And we've got a brain that is affected to the point where emotional kind of parts of the brain take over with the processing. So we've got a whole heap of different targets for our drugs, and we'll have a look at those in a bit more detail. So osteoarthritis involves pretty much all the components of the joint. We've got inflamed synovium, we've got reduced viscosity of the joint fluid, we've got a narrow joint space, we've got random osteophytes, we've got cartilage that's anything from got minor deficits to pretty much not there at all. We've got subchondral bone thickening. It's all not good. So it's a progressive painful condition of the joint. But when we're thinking about osteoarthritis, we're not just thinking about the dog. We also need to think about the owner. With every dog, we've got an owner. If we've got a dog who's got this motivational affective component to their pain, we know there's some really good new evidence that depressed dogs equal depressed owners. Really interesting. There's a couple of studies showing what happens to owners when they can no longer walk their dog in the way that they used to do. The effect on their quality of life is really poor. And often we'll see owners, and because we've got more time, they tend to be much more open with us. And because we're not thinking about things like an orthopedic surgeon, they're very anxious for their dog. And we have then a cycle where we have both the owner and the dog in a situation where they would be, might be better. And this is a quote from Hannah on Cam that I think is really important. Osteoarthritis isn't just a disease of the cartilage or of the joint or of the body or of the dog, but it's a consuming, emotionally and physically debilitating disease for owner and dog. And as vets, we tend to prescribe and leave. But I think once you get a grip of how this is affecting the relationship between the owner and the dog as much as anything else, and how how challenging this is every day for the owner and the dog. It is, it's something that we really are ethically bound to maybe do more for than we currently do. If your dog has been your mate day in, day out, you've walked it 3 times a day, you've gone running with it, you've done agility with it, you've done loads of other stuff, and you can't do any of those things, it's a big emotional impact. If you think of an older person whose dog is their only companion, they maybe done agility. Agility brings their social life. Now dog can't do agility and they've got no social life. For us as vets, are kind of, hang on, but we do need to think about this, because it goes just beyond what's happening in the joint when we're thinking about how to manage it. So how do we manage it? I don't have time to talk about this, but we need to be aware that pain assessment is fundamentally very different to the assessment of acute pain. And whilst there are some, there's lots of types of objective pain assessment out there, we need to be aware that we're assessing the motivational affective component, not just the intensity. So things like a visual analog scale of 1 to 10, not really much good for this. We need to think about what's going on in the whole patient. There's quite a lot of reviews on this, and for the vets out there, this is it's a good one. This is Jackie Reed, who is behind the Vetmetrica health-related quality of life scoring system. But structured behavioral observation, if you just remember that, it's not just about how much the joint hurts, but how the animal's behavior has changed. This is the how it makes you feel component to the pain experience. So if you're talking to owners about pain, then probably not going to vocalize, they're probably not going to do lots of things, but it's about asking the behavioral questions. And these are just some great tags from Cam about what the animal might be doing that's different. And whilst I'm on my stuff about pharmacology, it's really important to note that this is kind of the top of the pyramid. We've got to find pain. We've got weight management, which, I think is absolutely fundamental, like really, 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 really important. It's just not something that we can do very quickly. But to me, it's the single biggest thing that you can do. We need to adapt our environment. We need to adapt our exercise. We need to do everything else to keep this animal fit, strong, and healthy. And then we start talking about drugs. And certainly in the NICE guidance for people, which obviously is slightly different, the big plug is on this stuff first before we go to drugs. Drugs and more drugs are not good. As Hannah was saying earlier, and as one of my brilliant physiotherapy colleagues says, more rugs, fewer drugs. We can improve things in ways that don't involve loads of drugs. I just don't have time to talk about that tonight. So we're going to talk a little bit about pain targets from a pharmacological perspective. We're looking peripherally. So our kind of rec joint on the left, you can see that osteoarthritic joint. We've got lots of potential bits that have got lots of nociceptor activation. We've got lots of bits that are, we've got inflammation. We've got this big soup. We've got targets like nerve growth factor. We've got targets like prostaglandin. So, as I mentioned, non-steroidals, they target prostaglandin. I'm not going to talk about them extensively, but as I said earlier, prostaglandin is a massive driver of pain in the periphery. Non-steroidals are multiple drug families. If they are well prescribed, they have minimal side effects, okay? They do have side effects, but most of them, and we have this data from James Hunt's study. This is from an analysis. Most of the side effects of non-steroidals are either due to poor prescribing or poor compliance, i.e. owners not being cognizant of the contraindications or continuing to give the drug when something else has happened to the patient, which suggests that they shouldn't. So there's lots of different drug families, but fundamentally the non-steroidals are targeting the prostaglandin in the periphery, also in the spinal cord, that are heavily involved in peripheral sensitization and to an extent involved in central sensitization. So they are a really good primary option for analgesia. They're targeting an appropriate part of this pathway, an appropriate site, and therefore they should definitely be considered. They're not appropriate for every case, but they should not just be, oh, we don't like them because they've got too many side effects. They need, if they are prescribed effectively and administered appropriately, they are as good drugs as any other. Galliprant, this is Elanco's information because I had to use it as it came from them, is an EP4 receptor, and this is on the prostaglandin pathway, but it's a little bit further down it. So if we look at the pathway on the right hand side, we've got cell injury, we've got phospholipases. They're inhibited by corticosteroids. So corticosteroids historically were used for osteoarthritis, but they've got so many side effects. Don't want to go there. They cause all sorts of other problems. A bit further down that pathway, we've got arachidonic acid and the cyclooxygenases. And as you can see, they have an effect on the prostaglandins, on PGH2, which is then is the precursor of the prostaglandin E2 family. Prostaglandin E2 family, EP4, part of that family, is blocked by Galliprant. So you can see that the non-steroidals work further up the pathway. So they're a little bit more wider in their effects on the prostaglandins, whereas Galliprant works further down the pathway and it's much more specific. So therefore, we can kind of quite reasonably say that the likelihood of side effects it's still there, but it's lower because they're not ulcerogenic, because they don't affect the prostaglandins that protect the stomach from ulcers, and they don't affect the thromboxane A2, which affects coagulation, and they don't affect renal blood flow in the same way. So it is just, there's only one drug in this class at the moment, and Galliprant has a license for osteoarthritis, and it is working on this prostaglandin pathway. It's just looking at a specific prostaglandin receptor. So we kind of got two classes of drugs which are working on the same pathway but at different points in the pathway. The classical non-steroidals work higher up in the pathway and have a broader range of effects, but potentially a broader range of side effects too. Completely different pathway, nerve growth factor. Nerve growth factor is essential for the survival of sensory and sympathetic neurons during development. As it says on the tin, it makes nerves grow. So when you're in utero, when you're a juvenile up to being essentially mature, it is there for sensory and sympathetic neuronal development. It's really important for that. So one thing, this drug must never be used in, any anti-NGF antibody must never be used in breeding animals or in youngsters. As I kind of alluded to earlier, in the adult, nerve growth factor, we think is kind of, we need small amounts to maintain nerve function, but we think it's also a bit, it's not really got any useful function as far as we know. Bit to maintain normal nerve function, but actually there's a lot of it in excess. Nerve growth factor is heavily involved in pain plasticity, and it binds to the tropomyosin kinase A receptor, which is this TrkA receptor, and then it gets a mechanism, this complex gets transported back up to the spinal cord. And at the level of the spinal cord, it's basically saying, hey guys, let's make some more nociceptors and more ion channels. If you've got more pain receptors, you've probably got more pain. So we get increased nociception. And over the last 9 months, we have 10 months, we've had canine and feline anti-NGF monoclonal antibodies have been licensed in the UK, R, and in fairly widespread use. Now, I don't have time to go over loads of this data, but Librela is the Benivetman is the canine version, and it's certainly, when you're thinking about drug use in osteoarthritis, it's a licensed drug, it's licensed in the species, it's licensed for long-term use, it's hitting a pathway that none of the other drugs can hit. So if you're looking to target pathways, then this is a good target, and this has been NGF has been a potential target in chronic pain for a very long time, and there's ongoing work in people looking at similar drugs which are not unfortunately yet licensed in people. But these anti-NGF monoclonal antibodies, so the canonized or feline, felinized, they are proving to be incredibly effective in part of the management of osteoarthritic pain. What else in the periphery? Well, the periphery is the joint, so we can think about intra-articular medication, and we could talk for a long time about that. We can think about platelets, stem cells, arthritis, synovitin, loads of stuff. But essentially, we're also targeting the periphery. We're trying to take away that nociceptive response at the level of the joint. Still kind of the same thing. We're just trying to stop stuff going to the spinal cord. If it doesn't go to the spinal cord, it can't go to the brain. So that's why this stuff in the periphery is really important. If you can downregulate in the periphery, you don't need to worry as much about the spinal cord because nothing is going up to the spinal cord. But if stuff does get to the spinal cord, then we need to think about what we can do at the level of the spinal cord to try and stop the magnification and stop the central sensitization, stop the low input becoming a massive output to the brain. So we've got a fair number of drugs there, and some of those you'll be familiar with as well. So gabapentin binds to the alpha-2 delta-1 subunit of presynaptic calcium channels. Well, that's a bit of a mouthful, but what it basically means is it's kind of a bit of like the gears in neuropathic pain transmission. It kind of slows things down. It reduces neuronal excitability after nerve or tissue injury, particularly after nerve injury. It has a really complex mechanism of action. There's lots of different other things that it does. It is a first-line agent for neuropathic pain. So it's used preemptively if there's a risk of neuropathic pain. And in people, you get high-level relief, which is 3 points on a visual analog scale. And this is in relatively in people's own self-reported pain. Remember that this is the gold standard in people, but it encompasses lots of different bits because they're thinking about their emotional bit as well. You get that kind of level of relief in only about a third of people. So putting a dog on gabapentin does not mean that you're fixing the pain. We need to be very aware of that, and we don't have great pharmacokinetic or pharmacodynamic data in dogs, so we just need to be aware of that. It's not great for nociceptive pain. You know, there's nothing in that mechanism that I just talked about happening at the spinal cord that is going to affect a nociceptor. You know, there's no nociceptor at that level. It will modulate spinal cord pain transmission, but because it's kind of doing this to these excitatory neurotransmitters, it makes you a bit sleepy. Believe me, I've had it for a neck disc. I was well sleepy. Bit ataxic, sometimes somnolent. So we need to dose titrate, and we need to be aware that some dogs, particularly older dogs, don't tolerate it. They've become very spaced or sleepy. And if it's not weaned slowly, and you suddenly kind of you change gear and take away all the restriction, you can get rebound pain if it's not weaned pretty slowly. And I one of my colleagues who's got chronic pain is getting that coming off gabapentin, rebound pain. So we just need to be aware that this is not something to start, use for 2 months and then stop. Gabapentin and pregabalin are drugs of abuse in people. And then now for vets, they're under fairly strict legislation. They're under the Controlled Drugs Act. So for owners, that means that vets can only prescribe a certain amount. You can't keep asking for more drugs because we can't give it. We're not allowed to do that. There's a Controlled Drugs regulation which came in at the beginning of 2020, which has the implication is to try and reduce human abuse, but it does affect what we can prescribe and how we can prescribe it. So I said if gabapentin is good for neuropathic pain, what are we doing with it in OA pain? Well, it may modulate central pain processing, so it doesn't mean it doesn't have a role, but it's probably not the best drug because it doesn't have much effect against nociceptive processing. But many dogs with hip OA probably have LS disease as well. If you extend a dog's hips, you're probably going to be doing something at its LS. I'm no orthopedic surgeon, and if there's certain ones that I know listening, they'll probably be cringing. But genes for hip dysplasia and subsequent hip OA are often expressed in the same breeds as those that get lumbosacral disease, and it can be hard to differentiate. So if you've got those cases, it's probably not a bad choice. But just remember, fundamentally, gabapentin its main use in people is for neuropathic pain, and it would not be for me a first-line drug in osteoarthritis because it has no effect on nociception. Amantadine is a bit of a relative to ketamine. It has an effect on the NMDA receptor, on the NMDA complex. It's a weak dopamine and agonist and glutamate antagonist. Glutamate is an excitatory neurotransmitter, so it kind of downregulates that. I think it's fair to say that it's an add-on drug for patients with worsening pain, but it's an anti-hyperalgesic. It doesn't have effects at the nociceptor. So it's part of a multimodal choice, and it's not in the vast majority of cases appropriate to have a dog on amantadine as a primary drug in osteoarthritis because you're not targeting these pathways as effectively as you could. So it's part of a multimodal approach. Because you are looking to decrease this central sensitization component, and this central sensitization component, as we said, it's turning up the gain of the system. If you keep turning that gain up, it takes a long time to turn it down or wind it down if you're an old vet. That wind down takes a long time. So if you're going to use amantadine, you need to be prepared to use it for a minimum of 21 days before you can say, nah, it's not working. And again, this should be based on objective pain assessment rather than just perception. We can talk about caregiver placebo, vet placebo, all this kind of stuff. So, and it sometimes is a drug that's needed for life. It can be very effective. Unfortunately, I'm not sure that we know which patients it's going to be effective in. And obviously, if its primary action is at the spinal cord and part of the central sensitization process, where patients are heavily centrally sensitized, it's probably going to be beneficial. But I'm not sure that clinically as yet we know which patients these are. So I think that's just a kind of caveat. We do have one good study looking at it, which is now quite old, but it was the great Duncan Lascelles, who I love because he's always got a skeleton behind him when he's presenting in his office. But Duncan's done a huge amount of work on analgesics, and it was him that did the study. It was a well-conducted study, so it's just something to be aware of. But you can see in that study, they used a non-steroidal, so something that's acting in the periphery, something that's acting against prostaglandins, something that's acting against peripheral sensitization. And this is just a plug for a couple. There's a link on our website and also the guys that do Zero Pain Philosophy, Matt Gurney and Carl Bradbrook, who are good friends of mine. I would direct you towards that, particularly vets. There's some really good stuff about chronic pain on there. And ketamine. Most people, if you're a professional, you know it as being an as an anesthetic and agent. Everybody else knows it as an inverted commas horse tranquilizer, which I've never tranquilized a horse with it because they just hit the ceiling if you gave them ketamine and nothing else. But it is an analgesic in low concentration, so in sub-hypnotic concentration. So when we're talking about that, we're talking about giving doses that do not cause dissociation, do not cause overt sedation, do not cause dysphoria, do not cause anesthesia. It modulates this NMDA receptor. It's an allosteric modifier of it. We do not have great evidence for using canine OA beyond anecdote, but if you have a look at the Zero Pain Philosophy, there's some great stuff on there about how it might be used and how it might work. And then central pain targets, kind of running out of time here. Central pain targets are the brain. And what drugs affect the brain? Well, essentially, we're looking at the opioids, the SSRIs, the SNRIs, and tramadol. So we'll have a quick look at those. And paracetamol. Paracetamol has a lot more evidence for it in acute pain than it has in chronic pain. But paracetamol has loads of effects. One of the good things is it's got pretty rapid onset. It's a weak anti-inflammatory agent. It needs intact cannabinoid receptors, so it works through the cannabinoid pathway as well. It's a serotonin agonist, so it's working on these descending inhibitory mechanisms in the brain. And so there's pretty good justification for using it alongside non-steroidals because its mechanism is pretty separate. The only different bit is the COX-3. It's a weak COX-3 antagonist, but that's at the level of the CNS rather than the periphery like the other non-steroidals. So paracetamol we now know is pretty effective in acute pain. We've got some pretty good studies over the last few years, and its use in chronic pain is increasing. A lot of the efficacy is based on owner assessment, and again, zero pain philosophy's got some great stuff on that. But definitely, I use it a lot as what I call a rescue analgesic. So a dog's got a really good, stable plateau of analgesia from whatever else is going on, and then it has a great day out with its mates and is pretty sore. Paracetamol, we know you have it for a headache. It's got pretty rapid onset of action. It has a rapid onset of action in dogs too. Never in cats, in dogs, and it will allow you to rescue them if they are struggling a bit. You'll get anti-nociception for a short period of time. We've also used it in some of the patients who've been struggling and then maybe approaching the end of life, but the owners are still coming to terms with that. We'll use it before they go for a walk, or even dogs where actually once they get walking they're really happy but they need that additional analgesia to get them moving. Paracetamol is really good for that, but its duration of action appears to be variable and pretty short, so we're now talking about 3 times daily dosing and much higher doses than we used previously. But again, a lot of anecdote and hopefully an increasing evidence base. I know of a couple of ongoing studies for this, so hopefully something to keep your eyes tuned out, but you can definitely use it alongside non-steroidals. We've got a couple of studies, or certainly one's an abstract, suggesting a no increased evidence of side effects if you use the two together, at least in short-term use. So tramadol. Tramadol definitely affects the brain. It's a synthetic analog of codeine. Humans, cats, and dogs metabolize tramadol differently. So I've long discussed this with colleagues that I'm sure that some owners think tramadol will work because they have it, whereas dogs, the metabolism is extremely variable. The O-desmethyl tramadol, which is the active product of tramadol metabolism, the amounts that are produced and the bioavailability in dogs is really variable, and in some dogs it has a very short half-life. There is limited evidence in dogs of a convincing analgesic effect. If you look in Veterinary Anaesthesia and Analgesia, which is one of our really good journals, they reviewed this last year, and we don't have many great reviews in veterinary medicine in terms of analgesia, but there is the evidence base is pretty poor. So the fact that it's licensed is only the fact that they showed equivalence with the previous product on the SBC. Vets will know what I'm talking about. It's not, the SBC for licensed tramadol does not show efficacy, which is quite interesting. It just shows similarity with another tramadol. So, you know, we have licensed tramadol in dogs, but just be aware that I don't think it's a great drug. It may have effects on descending modulation, so it's serotoninergic, so it may benefit the affective component of pain. You know, we said that it has an effect on this emotional component, but only in a limited number of cases, and in many others, the sedation, the fact that it's so variable, the fact that we can't really show convincing analgesic effects in studies go against it. I'm not saying don't use tramadol. I'm just saying be very, very aware that, again, you can't prescribe it and assume the dog will be better. You need to be really looking for what its benefit is. And cannabidiol. So this definitely acts centrally. Cannabinoids, an umbrella term for cannabidiol, tetrahydrocannabinol, etc. Cannabidiol is the one that we are interested in from our perspective. Endocannabinoids have a big homeostatic role in the body, and they are really interesting in terms of their effect on descending pain inhibition, but they're also involved in motor coordination, memory, pain modulation, appetite, and a whole heap of other systems. The endocannabinoid system is massive, and again, it was something that certainly when I was a student was kind of glossed over as kind of existing, but don't smoke dope, so kind of don't worry about it. But we have 5 endocannabinoids that have been identified, including anandamide and another one that I can never pronounce, so we're not even going to talk about it. But we have 2 types of G protein coupled cannabinoid receptors. What's really important for those of you who are interested in CBD is that cannabidiol doesn't actually bind to these receptors. These receptors are very highly bound to by THC and other cannabinoids, but CBD kind of modulates the endocannabinoid system, so it's probably an allosteric modulator of these receptors. We've got a lot of evidence that it modulates anandamide, and it's got multiple targets. So CBD is actually not binding to the cannabinoid receptors, but it's modulating the endocannabinoid system. Cannabidiol is subject to regulation by for vets. We cannot prescribe without really careful consideration of the legal implications of doing so. Doesn't mean that we can't prescribe it, just means that we're going to have to be really, really careful. We have to use what we call the cascade. We can't give this without going via the cascade. This is legislated. We have no choice. Be aware if you're going to use CBD that lots of stuff on the high street may have no cannabinoids in it at all. And this is from data from a BBC and Michael Mosley that actually investigated this. Might have less than 50% of the stated content. It might contain solvents or heavy metals. It might contain THC or CBN, which are the psychoactive cannabinoids. So it doesn't mean that I don't think that there's actually a use for cannabidiol. I think that cannabidiol is going to be something down the line that is really important. But what I would say is if you are giving your dog cannabidiol from something you bought in a health food shop, you're actually breaking the law. Now, that's kind of the way the law stands, but be very aware that vets are very highly legislated when it comes to this, and we have no really good long-term studies of cannabidiol alongside other drugs and also alongside animals with comorbidities. I'm hopeful that that will change. I'm not cynical about it at all. Something I'm quite enthusiastic about, and I'm very hopeful that there is a big study about to start for prospective use of cannabidiol. But we do need to be aware that you don't know what's in a lot of this stuff, and neither do we really know what the long-term effects of these are. So I'm never going to say no, don't do it, because it's not something that I can necessarily have an impact on, but just be aware of what the implications are of over-the-counter use of an unlicensed, unregulated product that probably has not undergone what we call good manufacturing practice or good clinical practice. So we don't know what the manufacturing status of all these kind of things. So it's just to be aware of that. So what I'm trying to get at with all that stuff that we've been talking about is that it's about polypharmacy, but it has to be logical. We have to look at the type of pain that we've got. We have to look at the presentation of the animal to think about the type of pain that it's got. And then we can think about what might be an appropriate pharmacological approach. But throwing every drug that you have at the patient is never the whole answer. Once you start getting random polypharmacy, as I call it, you just finish up with a patient who's subject to lots of side effects without actually thinking about the mechanistic effect and targeting that mechanism for the appropriate duration to see if there is the appropriate effect. And this is a slightly different diagram that Di did, who's one of my physio team, who's amazing, but it's basically showing that NSAIDs and other medications are one bit of our little jigsaw. We've got got to identify pain. We've got to deal with the weight. We've got to get the diet and nutrition right. We've got to think about lots of other things. Dare I say it, we can think about salvage surgery. We can think about lots of other stuff, but drugs are not the answer. Fewer drugs, more rugs. Think about everything. That doesn't mean, I mean, all I do most of the day is administer off-licensed drugs to animals. It's a job. But you need to think about what you're doing. Make sure that you've got the right fire extinguisher in your hand. Otherwise, it's like pouring water on a chip fire. Just think about that. Okay, thank you very much for all this. Canine arthritis management. Remember, vets, cats get arthritis too, but I don't want to go out with my remit. So thank you very much for bearing with me. I got it to an hour, and I hope you found some of that of interest. And I really hope it kind of just wasn't all boring vet stuff. Thank you very much.
Not at all. It's not at all, Louise. It's incredible. And I think what you've managed to achieve is really keep everybody engaged. The numbers did not drop during this live. People stayed watching and listening. There's a few questions, so if you've got time just to answer a couple,
yeah, that's fine.
I'm going to just throw them at you. We've got a great one from Lynn, and we love Lynn. Lynn is our head ambassador and listens to every live, so thank you, Lynn. There appears to be different approaches to the use of non-steroidals alongside Librela. Some vets are fine with prescribing both, others are not. What are your views?
Okay, I am not speaking for, I'm only speaking personally on this, so I think that's really important, but I can explain why we have this oddity. Okay. In humans, long-term use of anti-NGF antibodies and non-steroidals together have increased the severity of something called rapidly progressing osteoarthritis, generally in younger people, resulting in joint replacement. So they have this syndrome called RPOA, where there's certain physiological circumstances can make arthritis progress from being mild to the point of needing joint replacement. As far as we know, there is no evidence of rapidly progressing osteoarthritis at all in cats and dogs, and you know, it just isn't there. And the vast majority of the cases that we're treating will probably have had joint replacements anyway if they were humans, because they don't have much cartilage left. So the reason some vets are okay and some aren't is the only data that we have from Zoetis at the moment is the use of 2 weeks of non-steroidal, and it happened to be carprofen alongside Librela, has not caused a problem. But if you actually look on the SPC, there is this concern about rapidly progressing osteoarthritis with long-term non-steroidal and Librela use. They have to put it on there, I think, and don't quote me on this because Zoetis might say otherwise, but I think this was an EMA requirement. So then obviously vets have read this and gone, oh, you can't use the two of them together long-term because of this theoretical risk of the development of rapidly progressing osteoarthritis. My view, and it's just my view, is that many of the dogs that I'm seeing are elderly, they've got multiple comorbidities, and they're very painful. They're in the severe category. So I put them on both because their joints are beyond, you know, any thought about rapidly progressing osteoarthritis. And if you look at the mechanistic bit that I talked about 45 minutes ago, the non-steroidals hitting the prostaglandin, then the anti-NGF antibody is hitting the NGF pathway. Two pathways, two big guns, should be beneficial. If somebody goes, well, you can have one or the other, well, I've got one arm tied behind my back in terms of efficacy. So that's why. But I totally understand why some vets are going, well, hey, the data sheet says this. So that is the kind of involved reasoning, if that makes sense, that you've got this potential risk with both of them together. We don't have long-term data. They're extrapolated from people, and therefore there's this concern. If it helps anybody else, I've had dogs on both since Librela first came out, and we're seeing them better, not worse. But that's, you know, that's a clinical perspective. That's not a legislative perspective.
Yeah. And I think it's one of those situations, what I will keep saying again and again, talk to your vet. Say, hey, can we talk about this? I understand of the data sheet. However, and have a conversation. I think sometimes we're so rushed, 10 to 15-minute consults, so much being covered, and you're moving out the door with questions still there on the tip of your tongue, but you haven't had the opportunity. So just ask for a bit more time, extended consult, send in an email. That kind of comes to this one, which I think is a brilliant question. Is growling while laying down mostly neuropathic pain, or is this hard to say?
I think it's hard to say. It's really neuropathic pain can be completely spontaneous because, as I said, you can get this ectopic discharge, or it can be associated with something that irritates the nerve. Like, for example, I've got a couple of cases when they'd avoid stepping up onto the pavement because when they did so, you get this lancinating pain and you get verbal reaction. So growling is not normally, I would say, and it's only, I can't prove this, it's normally an acute vocalization associated with neuropathic pain, out that hurt kind of thing, because it's this very acute pain. Doesn't mean it isn't. It's just that, you could have all kinds of other pain that's positional when an animal is lying down, and it doesn't need to be pure neuropathic. So generally speaking, neuropathic's probably more of a vocalization, a direct vocalization, but without getting a full assessment of the patient, what they're doing in different circumstances, it's really hard to know, to be honest.
Really hard to know. And I think from a practical perspective, film it.
Yes, video,
get to your vet and keep it on your phone for at the end of a drug trial. So if you've done, say, 4 weeks of a medication, cross compare. So don't throw that data away, use it as a reference.
We love videos because remember, the other thing is, and I guess this is slightly going off the drugs topic, but it's real. We get animals into our physio centre and we're fabulously, we're so lucky. We've got a separate building that's the therapy centre. Hannah's seen it. It's like a spa. Amazing. Pretty much every dog loves it. They come in and they're like, hi. And you're like, you're supposed to be 3 out of 5 lame and you're high as a kite and I can't see anything. So it's very different from what you see at home. So I'll often get owners to video at home, get the physios to assess those, or even I can go and talk to an orthopedic surgeon, because what you're seeing at home is the real deal. What you're seeing in the vets, be it your primary care vet or coming to see me, is either I'm a bit terrified, what are you going to do to me? Or actually, where are my treats? I'm really excited. So just remember that the adrenaline and the situational response changes what your vet can see massively.
Yeah, and I mean this from the bottom of my heart. If you're anywhere near Hitchin, give this lady a shout, because the facilities are absolutely unreal. It's the most beautiful place. And Diane Messam, she's done lots of lives with us as well. She's your wingman, basically. The two of you team up is a brilliant combo. Here we go. Suggestions for meds that cover both OA and neuropathic pain for spinal compression. Again, hopefully it's covered in your talk, but anything you want to recap on that one?
I would address them from their mechanistic standpoint. So, if you definitely think you've got a neuropathic component to the pain, you're going to be looking probably primarily at calcium channel antagonists. They'd certainly be kind of first line in terms of their risk-benefit side effect profile, so potentially gabapentin or pregabalin, but with an understanding that they have their issues and they're not effective in every case. There are other anti-neuropathics out there, but you need to be very aware about what you're trying to achieve when you're using them. But gabapentin will not, generally speaking, address the nociceptive component of osteoarthritis. So you're talking about appropriate polypharmacy. So, are we going to be looking at a non-steroidal and potentially gabapentin? Quite possibly. Are we going to be talking about Galliprant and gabapentin? Quite possibly. Also, you need to think about this clinically in terms of if you address one type of pain, or if you address which is the biggest morbidity, can sometimes be an issue. That we see that we get many patients coming into neurology, but they also have osteoarthritis as a significant comorbidity. So look at that. So you look at the type of pain and then look at what you can do and look at the magnitude of that pain. And there's great, the CBPI, the Canine Brief Pain Index, has something called the pain interference score, which is like, actually, how much is this pain affecting this dog? Because remember that I've got quite a few patients who gabapentin makes them so sleepy that actually we're not benefiting the patient. So we've got to play that, we've got to play that carefully. But just emptying the drugs bucket into them, I definitely wouldn't do. I would, and don't, when you're changing your pharmacological approach, unless you've got a patient, sometimes I see them and it's like, come and see me or you're going to be euthanized. And yes, we will be very aggressive, but then we back off. We need to know what's actually having the positive clinical effect by objective repeated assessment.
Yes.
And then, we'll pull back a lot of the time, and just make sure that we've done everything else. So, it's not just about the drugs.
I think that's such an important point that people really worry about. And something that's said on Holly's Army all the time is, I've gone into the vet, I've got all these drugs. Is this it? Am I here forever? No, guys, no. I think the thing that can be really difficult for us vets is getting your trust that we need to see you regularly to fine-tune things. And I think there's a bit of a financial fear. I think there's a little bit of a denial thing going on. People disappear. And they might continue on these high level of drugs when you actually did want to bring them down, or they might give them for a period of time and then stop them and think that they didn't work and not come back. So please build a rapport with your vets and do reassessments.
And a lot of the stuff that we do, I mean, I appreciate I'm in a different situation, but we'll catch up by email. And I always say, look, this is plan A. We'll probably be on plan C by 3 weeks' time. We could be on plan F in 2 months' time. Every dog, the jigsaw is different. Every cat, the jigsaw is different. What works for one animal won't necessarily work for another animal. It's not just about getting a recipe book out. It's about working out what works for your animal. And as we move forward, we're always going to be fighting pathology. So the older the animal gets, the worse the disease process gets, etc. But also the vast majority of animals, we will see more frequently for the first 2 or 3 months till we get them vaguely where we want to be. And then often the physio team will be doing the majority of the work, or their primary care vet or whatever. But it's a case of, we want to get what we can and try and get as positive outcome as we can. So yes, we do need to reassess them. We genuinely do. But many vets will be quite happy to say, email me in a week, but do engage, because if your vet wants that, they want the best for your animal. And we make decisions based on the best available evidence or what we know. We think in this dog, this will work. Doesn't always. I mean, she's a fabulous dog, but I've got a Labrador who by rights shouldn't be responding as well to non-pharmacological stuff as she does. She responds, she's a dog that responds amazingly to acupuncture, to massage, to physio, to hang on a minute, all this stuff that I never believed in but she responds more like a sight hound with back pain, but she's responding. So I'm not giving her more drugs. And I think that's really, really important, that each dog is an individual and we're not just prescribing and turning our backs and, seeing them in 3 months for a represcription.
And this is what me and Louise were talking about before, in that many ways, managing OA isn't complex because we haven't got a huge number of tools, but what it is complex because we've got to manage the individual and the owner and all the variabilities in that person's life with their dog, and try and get the best and communicate well and get the reassessments. And that's where it can be quite complex. So help us help you. Come back for your reassessments, bring your data, have an open mind. I'm going to do a blatant plug. Cam's got some brilliant courses for owners so that you can go to your practice equipped. You can do your modular course, little 12 modules. Loads of people have done it now. Go in with a greater understanding to make sure you maximize that time with your vet and ask pertinent questions for you and your pet. Just one more question, because I think this lady's been really, really patient. Are there pain medications that you'd recommend for a dog on steroids that can't take non-steroids? She's actually also written her dog's on steroids because of IBD. This is a classic situation with people, comorbidity. What would you advise?
Are we talking about an animal with diagnosed osteoarthritis is the first question, and have they got any other pain comorbidities? So is we'll make the assumption that the primary pain is osteoarthritis. Okay, so it depends on where it is, because if it's, I don't know, for example, if you have a dog with a single joint osteoarthritis, then they are actually will often respond to intra-articular stuff, because you can then avoid exposing the rest of the body to a load of other drugs, if that makes sense, because you are targeting very directly. But to be fair, that's normally a referral or a second opinion type thing. In terms of what we now have available, or what will hopefully come back in January, in terms of licensed products, the obvious choice is licensed in osteoarthritis. It can be used alongside other drugs. It's not contraindicated in IBD, would be Bedinvetmab, so an anti-NGF antibody. There is no overt reason from that little bit of information I have there to say that wouldn't be an appropriate choice. Its availability that's the issue at the moment, and its side effect profile is better than gabapentin, and its specificity for the job in question is better than gabapentin. And we know that if this dog's on steroids, we're already battering the prostaglandin pathway very, very high up, at the lipoxygenase. We're creating a potential lot of other side effects, but we've already hit that pathway, so we need another target. So potentially anti-NGF alongside everything else: weight management, environmental management, potentially physiotherapy, potentially hydrotherapy. Depends on the joint, depends on lots of other stuff. But in terms of pure, you pick a medication out of the box, it would be an anti-NGF antibody, but you've got to look at the whole dog.
Yeah, definitely. And just because this comes up on Holly's Army quite a lot, when we talk about things like hydrotherapy and physiotherapy, I know that there is a cohort of people that go, it's not available, I can't afford it, I can't do the frequency, I work full time, I can't get there. Don't panic, guys, and don't feel guilty. Even if you were to have some time with a physiotherapist, they can still do land-based exercises. There are still things that can be done. And I just don't want you to go away feeling guilty. It's a really big, important thing for Cam.
No, absolutely. And I mean, Di does this all the time. My boy, who's now a bit old, is her model for all our home exercise plans. So, you can see the physiotherapist once and ask for a set of exercises, and they will provide you with progression. Now, it's not a perfect solution, but find out. There's lots of things I can't do because I work a million hours a day, that I can't take my dog for a walk 6 times a day. It's not going to happen. So we've got to work with what you can do and what works with your lifestyle. So definitely using the opportunity to seek that physiotherapist advice on one occasion and get a plan is way better than just kind of not doing that, because the physio advice can be so beneficial depending on what your dog's problem is. And say to them, be open and honest. It's the same for all of us. I can't do that because I can't inject my dog 4 times a day. I can't do that because I can't do this, that and the other. What works for you? Some people are prepared to put so much commitment in that I could never do, and other people have a really busy lifestyle, and we just have to work around financial and practical stuff.
It doesn't mean that you're a bad owner.
No, not at all.
So I'm going to say thank you. I'm going to leave Louise with another hashtag, knowing that you're using more rugs, less drugs. We want dog, not log. So hashtag dog, not log, because we both believe that weight is a massive problem. And we're now seeing these tree trunk dogs walking around as if they're normal. So guys, dog, not log. I'd like to say thank you to our sponsors. It's been an absolute pleasure to have Louise, and I'm really grateful to Animal Care for making this happen for us. It's been awesome. Louise is one of my absolute herons. I will say that to her face, because she is legendary with her knowledge, and I'm so grateful that she's sharing it with you, Cam followers. We're going to be back next week for a pre-Christmas girly get-together. The Facebook Live hosts, me, Nikki and Amy, will be here to answer your questions, so please join us before Christmas so we can all have a happy Christmas together. Until then, thanks, Louise. You're absolute legend.
Thank you very much for everybody hanging all with that hardcore physiology at the end of the day, and I hope it does help you understand something.
Awesome. See you later, guys.